Okay. Thank you for the kind introduction, Mr. Chairperson. Today, this is the task that I've been given to present regarding the evidence-based practice of RA application in shoulder surgery. So, first of all, why would you consider regional anesthesia in shoulder surgery? Wouldn't GA be good enough for everyone? So, these are the population of patients that you would rather avoid giving GA as a sole anesthesia, or maybe analgesia is good enough to prevent complication. These are patients with possible hemodynamic and respiratory compromise. Some is because of anatomically challenge, and in some patient with trauma in which you can avoid ventilation if possible. So with indication of regional anesthesia as sole anesthesia and also analgesia, we will be able to avoid very bad pain intra or post-operative, which could lead to high consumption of opioid. This will lead to sedative effect post-op, delayed extubation, PONV, and also this would lead to increased length of stay in the hospital and delayed discharge. So I would like to highlight in this special group of patients in shoulder surgery which requires beach chair position, because in this group of patients there will be dangerous effect to nervous system and also cardiovascular system. So this article would relate to the last slide. Okay, this paper is published on the 2013, trying to show the effect of general versus regional anesthesia in beach chair position. So as for hemodynamic, the heart rate is not much of a difference. But then if you see that for the BP, actually starting at the minute of 12 post-induction, the BP is actually lower for the GA group, the black dot for the GA group. Oh, sorry, this one, black dot for the GA group. And then there is in fact a little bit of hypotension in the regional group as well, but it's actually very short, actually, but in the minute of a few minutes only. So in this GA group, they require a lot more of intervention. About 70% of patients require intervention, and then the dose of vasoconstrictors is used is more. But actually, if you see, there's actually the dose of phenylephrine in the RA group is actually 0, maybe because the BP pick up with volume instead of giving vasoconstrictors. So the cerebral deoxygenation is actually significantly more evident in the general anesthesia group as opposed to RA group. And then the CDE, which is the cerebral deoxygenation event, which the defined by the drop in cerebral oxygenation more than 20% or the value of less than 55% is more evident in the group of GA. So in some of the GA group, despite having adequate BP, actually they showed that the oxygenation is more even with the adequate BP, about 50% of patients. So this study conclude that the drop in flow rather than pressure could contribute to cerebral deoxygenation event. So I think everybody here is familiar with Interscalene block. So this block is about 100% success rate in the trained hands. Is considered the best surgical anesthesia. It targets the C5, C6 ventral ramen at the level of cricoid between the scalene muscle, which give rise to 4 or even maybe 5 if you include musculocutaneous for the innervation of the shoulder. So there are many complications of the interscalene block, but among those which actually frequently mentioned or measured in the articles is the phrenic nerve palsy. So the thing is, although this is the good block, the use is restricted in patients with limited result, although this group would benefit most from the opioid sparing effect. So I know that everyone here is more excited on going on the new techniques, but let us just refine our techniques a bit to mitigate the risk of having phrenic nerve palsy. So the first one that we should consider is the effects of volume. So among the articles that I go through is that the minimal effective analgesic volume of RAPM 5% is only 0.9 mils, and according to the article that the effect lasted about maybe 6 hours, and then this study includes patient for daycare surgery. So when you go as high of 20 mil, the incidence of phrenic nerve paralysis is almost 100%. The same author, Mr. Riazi, find out when you cut down the volume to 5% to 5 mil only, the incidence of phrenic palsy cut down is half by 45%. And then the analgesic effect is also the same, although you cut down the volume. So as for the studies, as volume for anesthesia, the lowest volume to date that I have found is 5 mil of Propi, 0.75% for anesthesia. So anesthesia, but according to Gaultier in his paper, there's a 25% failure rate if you use this much of a volume. So to increase this success rate, Mittal has used a volume of close to 9 mil of Propi, 0.5% to increase the success rate of block. And then with this almost 10 mil of volume, the incidence of phrenic nerve paralysis is actually 60%, according to the other author, Mr. Lee. So, what are the effects of the concentration? So the first paper by Wong et al. Showed the effect of LA of 0.2 to 0.1 ropivacaine on pulmonary function and analgesia compared to interscalene block. That reduced excursion is more on the 0.2% group. But although there's no desaturation in both groups, actually when you measure the spirometry, both groups had reduction in FBC, FEV1, and PEFR. And in these two groups, is actually the pain consumption is only increased after 24 hours in 0.1%. So, and this study by Cheng Shu showed that the median effective analgesic concentration for ROPI is actually close to 0.2%. So I suggest you don't go lower than 0.2% for analgesia. So if it's the same with the first study, there's no adverse effect on respiratory function, but this study doesn't measure diaphragmatic function. So what about if you use the same dose of ROPI 50 milligram when you adjust the concentration? When you increase the concentration to 0.75%, the onset is faster. For sensory, it's about 5 minutes, and the motor blockade is about 10 minutes. Those in 0.25% failed to achieve complete motor block, but the analgesic effect is actually good enough. There's no significant difference in post-op analgesia, hand grip strength, and also phrenic nerve paralysis. Next, we move on to the effects of the site of injection. So for the first picture, actually, I'm trying to show you that's how it is by diagram how it should be. The fascicles is actually bounded by the epineuron, and then there's another layer of fascia sheet, okay? And in the ultrasound, you only see maybe hypoechoic shadows bounded by the scalene muscle. These two layers of cervical fascia and epineuron might not be able to see during ultrasound. Actually, it's difficult to see. So there are a few terms that I want to tell you that the intra-fascia or intraplexus injection mean that you're injecting outside the fascia sheath, and then subfascia or intrafascial injection mean you are injecting within the sheath, and then subepineurial injection means you are injecting within the epineurium. So the thing with injecting within the fascia sheath is that the incidence of hemidiaphragmatic paralysis is actually a lot higher, although the onset is faster. But then these two approach, the effect of analgesia and also the duration is actually the same. And the thing with the intraplexus injection is that the incidence of paresthesia is actually higher. And then the thing is with this injecting within the sheath is that you will have increased risk of having subepineurial injection. What's the problem with epineurial injection is that it can cause epidural spread regardless of volume, because the epineurium is considered as the continuation of the dura. So when Dr. David first described the superior trunk about 10 years ago. The case report is about a patient with moderate COPD who is scheduled for daycare arthroscopic surgery. This technique is combined with GA, and then patient was discharged on the same day without complication. That's good news actually. So the superior trunk actually has a similar sensory distribution to interscalene because it comes from the C5 and C6. It must be performed before the suprascapular nerve takeoff. So the advantage of this technique is that it is a more consistent anatomical location, because if you are aiming for C5, you might miss it because a third of C5 had a variant which run either in front of interscalene or go through the interscalene. So you might miss the C5 when you're targeting C5. And then the thing with C6 is that it's not uncommon for the C6 to be split into two. So when injecting between the nerve root, actually you might be having an intraneural injection. So it's actually dangerous. You are increased risk of nerve injury. So at this level, the nerve sheath is thicker, so the risk of nerve injury is less. And there is, because of the distance as well, there is less risk of phrenic nerve palsy, which range actually from 4.8 to 76% with volume of 15 ml. But the technique of injection, I must inform you, is different. Kim actually split the injection into two portions, and Kang actually injected the whole 15 ml at the posterior part. So this actually two approach of superior trunk. The first one is the standard injection, in which the C5 and C6 fused before the superior tongue take off within the green box. And then there is a supraclavicular approach, which you inject actually lower. So in this part, so there's a dotted white box there. That's the point of injection. So injecting this point actually could cause less spread to hemidiaphragm. So there's less spread to phrenic nerve palsy, and hence less spread to phrenic nerve palsy. So this meta-analysis on comparison of superior trunk to interscalene for the effect on phrenic nerve palsy is actually just presented in September last year at the World Congress Regional Anesthesia and Pain Medicine. It includes 4 studies, and it shows that the incidence of hemidiaphragmatic paralysis at 30-minute post-block is actually a lot higher in the interscalene loop. Interscalene block, which is about 76%, and complete absence of hemidiaphragmatic paralysis in the superior trunk is actually about 66%. The incidence of Horner syndrome is actually higher in the interscalene block. There is no significant difference in the duration of motor block, duration of analgesia, cumulative opioid consumption up to 24 hours, and also patient satisfaction. So this is now considered a new golden technique, okay, because of superior analgesic efficacy, equivalent analgesic efficacy, and superior safety profile. So let's move on to the suprascapular nerve block. We start with the anterior block first. So the block is done under the subarachnoid plane. So at this area is actually easier to recognize because of the you're using the arachnoid as a landmark. So the success rate is actually higher here because actually if you use the volume of 5 ml as showed by SSNB at 2019, 5 ml can cause spread to about 90% of subject to superior trunk, 80% to middle trunk, and also 20% to of inferior trunk. So actually maybe it contributes because of the spread to the superior trunk and also brachioplexus. But then the 5 ml can cause staining to the phrenic nerve as well, about 20% of subject. So if you're using anterior suprascapular nerve block, you might be able to avoid doing block to axillary. Okay. So the posterior block is done on the suprascapular fossa. So you put the probe on parallel to the lateral and then tilt the probe anteriorly. So as opposed to doing block at the notch, you are doing block at the supraspinal fossa is easily much easier. So the axillary nerve block is actually done at the posterior part of the shoulder. The linear probe is put between the acromion and axillary fold. So you will find that this space will be bounded by teres minor above, teres major below, and both on the sides by the proximal by the humerus and also triceps. So this meta-analysis on the suprascapular nerve block and axillary nerve versus interscalene is published under 2021, which includes 10 articles which fits criteria. The volumes of the LA is as shown. So the pain score for interscalene block fares better up to 6 hours, and there's no significant difference afterward. This could be contributed by the fact that this suprascapular and axillary nerve block is actually have incomplete coverage. You're actually not covering all the necessary 4 or 5 nerves as opposed to interscalene. So the pain score later become comparable as the block wears off, so it becomes more or less the same. So as for the complication, these shoulder block lowers incidence of numbness, tingling, weakness, hoarseness, and also subjective dyspnea. And there's no significant difference for hoarseness and PONV. So as for patient satisfaction, good satisfaction for both. It might be because of when you say that the pain control is better in the interscalene, actually maybe it is balanced by the fact that movement in the shoulder block group is better because of less weakness. So they concluded that this nuclear block is actually an effective and safe analgesic technique, and it's an attractive alternative, especially to those with comorbids. So this RCT just to show you the effect on ventilatory function. The incidence of hemidiaphragmatic paralysis for the anterior suprascapular nerve block is actually 30%, 1-3 as compared to interscalene 80% with better spirometric test. And then all the effect is actually almost recovered by 24 hours and none experienced dyspnea. And now we are comparing anterior and posterior block. So as compared to this shown in this slide, the incidence for anterior for phrenic nerve paralysis is actually 36%, but for posterior only 2%. In one of the patients in anterior group is actually very severe respiratory compromise requiring non-invasive ventilation, and then this leads to delayed discharge because this study is done for a daycare patient. There's a clear advantage of anterior technique as compared to posterior because of ease of technique and also higher success rate and less opioid consumption. So what does the guideline say with all this evidence? So according to prospect guideline which published on 2019 for rotator cuff repair surgery, recommendation related to regional anesthesia is grade A for interscalene, both single shot and continuous. Grade B for suprascapular nerve with or without axillary nerve block, and also grade B recommendation for IV dexamethasone as an adjunct. And for joint replacement surgery for shoulder, NICE guideline published a guide on the June 2020. But however, there's not enough evidence according to the panel because mostly the studies are small and low in quality to support any specific anesthetic approach. So they recommend to discuss different anesthetic approach with patient. And they also suggest for future research on shoulder joint replacement, comparing GA with LIA, with regional, mainly in the studies include interscalene, and also to compare newer blocks as well. And then to study more on RA for daycare shoulder replacement. Thank you.